He'll be discussing the neurobiology development and psychopharmacology in the eating disorder patient. Today's EADS code is 12 through. Dr. Mosman completed his medical education at the Texas A&M University Health Science Center and his psychiatry residency at the University of Arizona Health Science Center. Then he completed a fellowship in child and adolescent psychiatry at Western Psychiatric Institute and Clinic. Dr. Mosman is currently an assistant professor at the University of Oklahoma College of Medicine. Dr. Mosman is a staff child psychiatrist and the medical director of the eating disorders program at Laureate Psychiatric Clinic and Hospital, and has various leadership involvements and engagement with the Academy of Eating Disorders and community engagement in child and adolescent psychiatry and eating disorder groups. Dr. Mosman does not have any relevant commercial financial arrangements related to the content of today's presentation. Please give a warm welcome to Dr. Mosman.
Great, thanks guys. Nice virtual. If Delta ever gets rid of us, then we'll be okay. So let me share screen here and do a presentation. All right, everybody hear me okay? All I can see is there, so this is all good. All right. All right. I can see Rhonda and Austin. Hear me and see everything okay? Okay, let's get started. So when I think of doing this for people, my job has become sort of very unique. And so thinking about doing grand rounds for psychiatric residency. So first thinking generally about psychiatry in general, which is certainly rare in the Midwest, and then certainly being a child psychiatrist is a in need thing, and then I've been working in the eating disorder field for almost 20 years now. So and then there's probably child psychiatrists who do eating disorder work. There's probably a handful of us across the country. I also get the privilege of working, since we're a not-for-profit, affiliated with OU, but we also have the Laureate Institute for Brain Research. So I work with Dr. Kalsa doing some neurobiology research. So my presentation sort of really starts out, I always think about psychiatry and neurobiology in this sort of umbrella. And then as a child psychiatrist, I always have to keep in mind what's happening in development, especially with psychopharm stuff. Kids are not, and even adolescents aren't just little adults. And so how does that work as far as both the psychopathology as well as how we use medications and how they interact differently? And then further layered into that, I'm dealing with eating disorder patients, the most common which are anorexic patients. So you're dealing with all the nuances of how nutrition also affects neurobiology, how eating disorders sort of affect the entire process sort of over time. How do we change slides here? Go over here. So I'm going to talk a little bit about brain development. And I actually also get to work on the ABCD study here. Laureate Library is one of probably 15 sites throughout the country where we're doing some neuroimaging of adolescents as they starting at age 10 and as they mature. So talking a little bit about what happens in brain development, what that means is in differences that you're going to see in psychopathology, as well as what that means different as far as treatment is concerned. Let me get where I can. All right, and then review of talking about neurodevelopment and how that works, and then review of psychopharm issues over time. See if I can move this here so I can see my entire slide. There we go, that'll work. Perfect. All right, so And being a child psychiatrist, talk about neurodevelopment. The first thing as a child psychiatrist that's most hard is that, so you sort of, again, you take what general neurobiologic research do we have? How does that neurobiologic research actually apply to psychiatry and the meds that we use? And then you start talking about neurodevelopment and using meds in kids. And unfortunately, the literature base, the science base we have is less. But what do we know about neurodevelopment when it comes to psychiatry? Is that certainly we know that half of all mentally ill adults exhibit symptoms by the age of 14, 3/4 by their mid-20s. We know that brain development's really not done until their late 20s. So there's, starting to think, I think when it came out, thinking about schizophrenia, bipolar disorder, it's easy when it's ADHD and those kinds of things, but these are all neurodevelopmental illnesses where symptoms present, and it's, clear that, in order to understand the origins, especially something like in bipolar disorder, where we know the sooner you treat, the less substance abuse, et cetera, the less kindling they are, the better outcomes that you have in patients. And again, we have so little data that talks about, well, during development, how do you treat it? Do you treat it differently? If you treat it earlier, do you have better outcomes in all brain illnesses and mental illnesses? So I think there's preciously little known about how that does, and then how my interactions with patients, if we get them sooner, make a difference when they're adults. So since we're all just fancy mice, there is this cool research study I found that talked about, that there is a mouse that lacks gene that looks at one of the subtypes of serotonin, the 1A receptor, and that they notes that they develop anxiety-like behaviors in adulthood. I think when they put in a maze, they get super stressed out or whatever. However, if they're able to briefly sort of turn on that gene in this sort of very early developmental period, the anxiety behaviors don't develop, right? And if you turn it on too early or too late, that doesn't necessarily provide the protective effects. There seems to be some timing. And so understanding timing, treatment, timing of when we use meds and what impact that does later, again, these are things that I think are important for the field, as imaging and artificial intelligence and other kinds of things can give us more information about, the impacts and how those lead to things down the road. So there's, this broad field called translational developmental neuroscience, right? And so this is basically, I think, trying to do what, through, research domain criteria and stuff has happened in psychiatric research over the last, 10 years, 15 years, which is like trying to come in from bioinformatics and, computers issues, AI issues, neurogenetics, biology, physiology, neurology, psychiatry, epidemiology. And so start to understand, like, what's the complete piece of the puzzle, right? I think all this way in medicine, probably in mental illness, the least of all, just because we're all, especially with the pandemic, so overwhelmed trying to take care of acute illness and crisis, that you forget, like, what does prevention look like? What does it look like to treat these illnesses earlier? How do you put together interventions to lead to better outcomes? And so I think trying to think about this, the way that we're trying to do the rest of medicine, the way that US, I think, does poorly, which is it's so much about cost and treatment and partition care that, integrative care becomes sometimes more difficult. So, what are some major keys in neurodevelopment that are important for our patients, especially my patients? So, and knowing, I think that most of you are adult people, but again, every single patient you get probably has had symptoms since they were young, and understanding neurodevelopment can be important. So, especially sometimes when it comes to stress and trauma, different places in development can maybe causes different outcomes. So remember, initially, we produce most everything, all of our synapses and stuff. We'll probably have a peak sometimes in 5 to 6. And then it's about stabilization and elimination. It's really about the pathways. It's about the brain subspecializing over time. Gray matter peak, peaks about age 10 to 12, and then slowly sort of decreases. Not that you're losing stuff cognitively, but basically, like, it's like you put down all the maps and then you've got to sort of select the routes over time. And then as that gray matter pulls back, there's this increase in white matter and myelination that happens. Certainly in ENSORs is why this process when people are in their latency age or early, teens or 20s, when they're, we lose all that myelin sheath, we lose so many of the supporting cells around the neurons when you're not eating. And so how does that impact neuronal development, maturation, frontal lobe development, et cetera? And then, the other things you see is, you got to think about the general process of development. What's the first thing we do when you have a baby and you're watching stuff? So first thing is, sensory, what can they sense? What can they see? How do they move? And then, of course, then you're starting to talk about higher level prefrontal and limbic cortices, right? How do we start to plan things? How do we process and regulate emotion? How do we use cognition to regulate emotions? How do these two systems sort of interact with each other to create us as being sort of conscious social beings? And you can sort of see this happening with different processes. Initially when you're a baby, you're just trying to get fed and eliminate and get certain needs met. Certainly as you develop, as we get into puberty, as we get into reproductive age, it becomes sort of important with social and other interactional things. And our brain sort of parallels, these development of these things over time. And as a result, we can start to see, development of certain illnesses over time. Autism is a really great example of like something that we're seeing, that there might be recognizable symptoms earlier and earlier. Some recent studies have just come out in the last 6 months showing that there's maybe certain types of interventions that the earlier you do them, that you reduce symptoms as they get older. I am certainly on the downhill track in my 40s, but pruning and elimination of synaptic spines and prefrontal development, really definitely in the late 20s, maybe the early 30s. So this, reorganization, planning, prefrontal cortex things, development is really not completed with a true adult brain until you're in your late 20s or early 30s. And so, I think when we think of, psychiatry and the like, then certainly we're also thinking of emotional regulation, right? And, I will tell you, as we look at DSM, as we look at sort of how we talk about mental illness over time, you end up, are you a lumper or a splitter? Do you believe in the DSM defining smaller and smaller illnesses, or do you believe that it gets where people become too specialized and you lose the connections of things? So when I look at especially emotional regulation, I look at that. I look at this general concept of brain stress resiliency, right? That when you look at these studies of serotonin receptors over time, you look at these people that have higher risks of depression, lower risk of depression. I think what you see is that people are born with a certain amount of brain stress resiliency. And most of our interventions, whether it be therapy or meds, tend to increase. It's not natural. We're not flooding the brain with dopamine and creating natural happiness hormones to make people forget about their problems. We're actually trying to make their brain more resilient to taking on stress without leading to sleep problems and depression, anxiety, panic attacks, etc. So, looking at this of how we develop emotional regulation, how do we develop brain stress resiliency over time is probably important as we look at psychiatric illness. So amygdala, certainly the alert center of the brain, increases in volume between 7.5 and 18. And then again, as this gray matter is sort of creating these pathways, we're seeing this connectivity with prefrontal brain regions, as well as orbital frontal, ACC, and, which is certainly so important in, OCD and in regulating how we interact with our environment. Dorsolateral prefrontal cortex, really that sense of ourselves and personal control that develops in therapy, certainly important during puberty, right? And so you can start to see how it's not just what happens and do you have a disturbance in these kinds of things, but it's also what happens with these connections. And these connections properly done, are they affected by trauma? In my case, are they affected by nutrition? And how does that lead to not only how the pathology is expressed, but how does that lead to how interventions might impact them over time? So these three systems of maturation, prefrontal cortex and regulatory control. I mean, the most example obviously being ADHD, and this ability probably for prefrontal cortex, reason our brains got big, the last thing to develop, that sort of has regulatory control on how do we manage and understand the rest of our emotions, and how does that lead to how we make choices and plan out what we're going to do or not going to do. Whether it's dorsal or ventral striatum, we're talking about reward and approach behaviors, right? So much of mine with my patients, my anorexic patients, they don't have adequate working reward systems, right? And when it talks about reward systems, so many behaviors when it comes to anxiety, let's take for instance, right? So I'm gonna, again, not everything's black and white, but if you take two broad categories, if you experience anxiety, you have the choice of, well, do I just cave up and avoid everything and Emily Dickinson myself in my house for 10 years because I don't want to experience anxiety? Or we have those opposite people with substance abuse, bulimia, et cetera. And a lot of those people don't have adequate reward systems to overcome things. They have over adequate and over quite a sensitive systems that provide punishment. And so they end up more in an avoidance mode. Or do you have a patient that when their brain stress resiliency is under approach, they're just impulsive and how do I make my brain feel good as soon as possible? Really active reward systems. And so drugs, alcohol, bulimia, things become ways for them to modulate it. And then certainly the amygdala, certainly very prominent in PTSD and those kinds of things. How is that interaction lead to avoidance or approach behaviors over time? And of course, even as I'm trying to talk about these specifically, you can see how they interact, right? So you got to have some reward, you got to be alerted or not alerted to what the danger is, and then you've got to make some decisions about how your behaviors change things over time. Right, and evolutionarily, when we think about having anxiety, having emotional regulation, there's different things that become important, right? So much of our anxiety is good for, it's bad to be paranoid until there's a real crisis, right? So things like paranoia and anxiety have reason in our society evolutionarily to stay around, right? They make you contributing members. Intelligence and anxiety are probably related. Empathy and anxiety are probably related, as we're sort of a population-based evolutionary mechanism. If you're anxious, you're better able to take care of those around you. There's a reason why these probably develop the way that they do, and there's a reason why they stay with us throughout evolution. I would even say, as we talk about, I have 2 teenagers at home. So we talk about lack of prefrontal cortex, impulsivity, behaviors, emotional regulation issues with a teenage girl for sure. Evolutionarily, I think some lack of caution and prefrontal lobe mechanisms for young primates when they're not the top of the dog makes them go out and find other things could be beneficial. There's a reason. Also, our brains have been so complex that, how long they're in utero, how long they need care from people. Like we prioritize these things with prefrontal development that really take a long time, that are taking 20 or 30 years to fully develop. And so, but that development of planning allows us to take over the planet and do what we need to do. So I think when you go back to evolutionary mechanisms, you can start to see purposes behind emotions, why this is connected to prefrontal cortex. And for me in eating disorders and talking about these kinds of things, it is this development, especially for young women when they hit puberty, that they have this increase in amygdala activation, never mind if you had trauma or neglect or anything else is going on in their background. They tend to have some traits that we'll talk about. And that there's even mechanisms with eating disorders as far as them being overly top down, overly anxious, overly perfectionistic, that can, again, still be survival oriented, right? If I'm up in the north, an anxious white young female up in the north, and but it causes me to be very cautious and ready for the winter, maybe that would be, give you an evolutionary advantage. So, trying to think about these things, unfortunately, the studies aren't there, but it starts to become important of why they're around, why they're sustained, and then try to think about how this then leads to psychiatric illness and diagnosis, how it leads to medications and interventions, and how it leads us to think about why those things work or don't. So, as we talk about this baseline, so I sort of have this belief in probably all mental illness, but I work in eating disorders, so I'll talk about anorexia and bulimia, that, there is this genetic brain stress resiliency, underlying current that we're probably born with, right? Introversion, extroversion, anxiety, intelligence, ability to do math. There's some really good studies to show that some of these are pretty hardwired, right? And you can maybe change them over time. But there are certain things that probably medications and therapy and stuff are not going to totally change. And so when you start talking about recovery and expectations for what somebody will change, that will be important. So as I work in anorexia, to give you sort of like a specific example of what I work with, what we know, so you do these studies basically, and you take two groups of patients that look as similar as possible for educational level, intelligence, et cetera, anything that might, so that the groups look as similar as possible, except one is at anorexia, one is not. And then you take back and look at their development, how they grew up, and figure out different traits that they've had and see, are there traits which place one at a higher risk than another to get certain illnesses. So when we do that in anorexia, and you can see, and there's references at the end of my slide, there's several studies that look at different things that people with anorexia had before they ever went on their first diet, hit puberty, things went off rails, and ended up with BMIs of 13 or 15 or whatever. And negative emotionality and low self-esteem, perfectionism, anxiety, harm avoidance, inhibition, picky eating, interoceptive awareness problems, GI somatic issues, obsessive compulsive traits, and then lots of reward dependence, but low reward reactivity. So these are, again, starting to talk about these neurobiologic substrates, and then development is important as well. So for me, this idea of negative emotionality and low self-esteem is very prominent in this patient group. And they're usually a very intelligent, successful group. But this low self-esteem really underlies their body image. It really underlies, lots of their depression and anxiety symptoms, how they think other people view them, et cetera. And this is something that I find even in my patients in solid recovery that seems to be lifelong, right? I do believe that there are people out there with sort of low self-esteem, and it probably serves some purpose to like serve others and be an important part of the population. There's probably some people with relatively accurate self-esteems. And there's some people with really high self-esteem, which, has certain benefits, get you the presidency of the United States, I guess. So, there's these things that can sort of happen over time that any one of these can get sustained in populations. Our population has low self-esteem. They tend to have perfectionism related to their anxiety. So perfectionism, anxiety, harm avoidance, inhibition, right? So we're studying a part of the brain called the insula at the Brain Institute. And, part of what we're looking at is how they experience their anxiety, how it relates to somatically how they experience in their body. And we see a lot of combinations with GI-oriented things together with the insula, together with anxiety that might, again, instead of ending up OCD with hand washing, might end them up in an eating disorder sort of road of things. But so they're anxious. When they get anxious, they tend to avoid. And they tend to avoid a lot of times because they're punishment sensitive, their reward systems don't work. That's sort of the reason as well for the picky eating. I do have a chat question, so let me see if I miss. I
think it was just a reminder about the code for the continuing.
Nope, there was a please comment on late onset anorexia nervosa, and I'll just remember that, and I'll do it while I'm talking about it. All right. So all right. So, and I think the person's asking that from the reason of the question of, well, this is all neurodevelopmental and it's all about hormones and those kinds of things, and how come we see patients who will develop it later in life and those kinds of things. And it's a complicated another topic. And again, the rules of anything is that can always be exceptions. A lot of those patients that I've seen as well have had brain stress resiliencies for issues for a long time. They've usually had some food issues. There's a reason, whether it's pregnancy or life events or those kinds of things that's made it come out later in life. So you have a group that's anxious. When they're anxious, they tend to avoid anxiety. They don't have reward systems. So even when it comes to food, they don't get a lot of reward for food. So it's easy to go without it. They tend to be inhibited to do less. They have low self-esteem, which oftentimes leads to body image issues for them. The altered interoceptive awareness has to do with their insula, that they tend not to understand and experience their anxiety as anxiety. Oftentimes experience it as GI or somatic issues or problems. And so, not everybody, but you can sort of see neurodevelopmentally that you're left with this population who's perfectionistic and anxious, who end up over time, looking out a pathway where, well, when I don't eat, because my stomach hurts because I'm anxious, but I don't recognize that anxious, I'm avoidant, and maybe it's the food that's a problem, maybe it's because my body's too big, that we can sort of maybe see this as a pathway that people will develop anorexia. Obsessive compulsive personality traits, and this is what I would point out too when we talk about lumping and splitting. About 40% of people with anorexia will have some significant OCD in general, and probably a majority of them have at least OC personality issues. And again, if you look at it through a different mold, I would say a substantial portion of my anorexic patients are really OCD patients, but instead of worries about cleanliness or germs or those kinds of things, it's worried about sort of weight and calories, and then the control, ACC issues, limbic issues start to become more important. These patients have a lot of reward dependence. They really feel like school and doing well and making good grades and stuff was going to pay off. And they're actually get good grades, probably more because they're scared of getting a B than they actually enjoy getting an A. They're scared that if people know I make great grades, they'll know how much of an idiot I am. Low self-esteem stuff comes in. So you can see how sort of this builds around this. But they really have low reward reactivity. It's a reason why at baseline, my pure restricting anorexics tend to have low levels of drug and alcohol use and early sexual promiscuity and, normal teenage stuff that you worry about. I often have to tell parents to parent these kids differently, right? So instead of being worried about all the stupid crap they're going to do before their prefrontal lobe is developed, you actually have to push them beyond their anxiety to experience and be amongst people and not just turtle up and stay in their house all day and be be kind of ruled by their anxiety. All right. This thing is being slow on me. There we go. So they do the same studies in bulimia nervosa. And again, the interesting thing in eating disorders, the interesting thing when you try to make diagnosis and you try to make things separate, then you're going to end up with, an older category, or you're going to end up with the fact that 40% of patients in their eating disorder lifespan have been diagnosed as anorexic or bulimic at one time. I really do think neurobiologically, these pure, avoidant, no reward, low self-esteem, anorexic, classical, typical anorexic patients are probably more, both genotyped and phenotyped together, though of course the genotype is complex, and probably have more direct similarities in their neurobiology than you do when you start getting into some purging and other behaviors that just happens to affect food, which happens to affect weight. Now, but as we talk about these anxious people who avoid and are using food due to somatic and insular issues, then I think at the opposite side in bulimia, knowing there's a lot of middle ground too, you have these patients who still have low self-esteem. They still, like 70% of the time, the girls that have entered high school tried restrictive eating or something as a part of it, but their reward systems work. They get benefit from binging and purging, and they're trying to control their anxiety. And so I think they end up in this more chasing phenomenon of getting anxious, seeking out reward to make that anxiety better. When you're bulimic and you eat a bunch of carbs and throw up, you'll tend not to lose weight, maybe even gain weight unless things get extreme. And so you end up continuing to sort of chase your tail with this. Still have high anxiety traits, still more commonly some OCPD traits, but a lot of mood lability and affect dysregulation. And when it comes to diagnostics, if I see anything in my population, if you're trying to treat people in crisis, when you're treating in a residential or acute setting, remember bipolar disorder is not the only thing that causes mood lability. Rapid fluctuations in mood. And then if I'm talking developmentally and you're a teenager, that's a huge difference as well. So remember, I see so many people with affect dysregulation and bulimia that get diagnosed with bipolar disorder. And if I just treat their anxiety and we can just stop them binging and purging and get them properly nourished, all of a sudden they don't look so bipolar anymore. On the other hand, absolutely have bipolar bulimic patients, and making sure that their mood is regulated, making sure that things are stable, that they're doing things makes a big difference. So diagnostics, seeing the water clearly can be important, not actively doing behavior, using substances, nutritionally being more stable, understanding where you are developmentally, understanding what meds there are and how they affect them. Again, our job is very complicated. It should be left to people with medical degrees and residencies, but that's not happening much more anymore either. So this is a group with high reward reactivity. So you're going to see this group seek out reward for them, both the act of binging simple carbohydrates and the serotonin and dopaminergic changes it makes, as well as for them, just like for some people who have chronic abusive self-harm, that undoing the purging provides a substantial relief for them, and they can get caught up that cycle. I like to look at it in similar ways as substance abuse. Some of the neurobiologic things look similar as well. So more impulsivity, sort of hair temperament, they're sort of chasing their anxiety by doing things that make themselves feel good. You can see these patients having issues with substance abuse, with sexually acting out, stealing, that's why you see sort of higher rates of borderline personality disorder, histrionic personality disorder, those kinds of things. And when you look at trauma and how they respond to the trauma as well, and how they seek out these things to make their neurobiology better as well. So, this study is from the 90s, because when you start to look at research, neurobiologic research, developmental research in anorexia and bulimia, it's so low. And I don't even know, this is now 25-year-old, 28-year-old research by some really good people. Janet Treasure is amazing. But I think it's good from the fact of, this was the only neurodevelopmental model of anorexia I could find in any sort of realistic literature source. And then how you think about things in a certain scope of looking at things, and then having to remember that there's so many things that impact that as well, right? So here's what they looked at in anorexia. So genetic factors, trait-based neural circuits, anxiety, avoidance, these kinds of traits that we see in anorexia before they get sick. And what do we see in early childhood development? Anxious, insecure attachment, dismissive, leading to difficulties in self-reflection, alexithymia. Their alexithymia rates are crazy among anorexics. Again, who knows how much is sort of insular and hard-based, how much is due to attachment, other issues that happen in development, or some combination of those, leading to impaired emotional processing and rigidity. Like the only way to control my anxiety is to be really rigid about my environment. And then we do actually see, when you start to look at hormones in people that develop anorexia, increased corticotropin releasing hormone activity, hypercortisolemia, right, which certainly with trauma puts them at greater risk, serotonergic overactivity, reduced amygdala, hippocampal volume, and let's just, if we pinpoint and look just at corticotropin releasing hormone, right, with heightened activity, when you have that, it causes decreased sexual increase, decreased heart rate, decreased GI emptying, decreased social, decreased exploration, appetite, decreased pain tolerance, increased anxiety. These are things that we all see in anorexic patients. You start to get chicken and egg, or is this directly of CRH or of other systems? It's a good question. They hit puberty. Estrogen tends to affect both serotonergic and hypothalamic axes more, right? There's a reason why a higher percentage of women get depressed, anxious, over time than men, and the effects of estrogen on that. Watching young women with PMDD when I'm giving them antidepressants, as this again something that impacts brain stress resiliency. And so start to see, and who knows, developmentally higher risk of, when you get to teenagehood of sexual abuse, et cetera. So again, you're always looking at development, you're looking at influence of your environment, and certainly, baseline influence of your neurobiology. And then, so the chronic stress, you do get, basically persistent elevated CRH release, serotonin changes, both as that you're gonna get to begin with, and then it becomes this sort of self-repeating cycle. And they think this is, and this is again for more of a neuroendocrine portion about how these patients sort of get stuck doing the same thing. I call it like the quicksand, right? Once you're not eating, once these things are already impacted, like all these things tend to lead you to get more stuck over time. This is the world's worst slide ever. And I put it up not so that I can give you an hour lecture about leptin and how these things affect, but again, so many times, especially early biologic research, when you're just trying to get the basics, is, people spend 10 years working on one of these squares, right? 20 years, their whole career is working on one of these squares. And sometimes you do it so much and you want so much of a connection of neuroendocrine and leptin and ghrelin and eating disorders that you forget the effects of all these other things and how these interact. It's truly why when we're looking at doing, we have 2 fMRI scanners at the Brain Institute, and we were doing, research into functional MRI stuff and changes, where you have to realize the complex systems these work out of, and that nothing exists in a vacuum, and that changes in any one of these can affect another, which then, depending on your genetics and baseline, can lead to different outcomes and different things. So this is why, and we're doing a lot at the Brain Institute, my hope of the next 30 years of research, especially when we're talking about neurobiologic things, it's a system that makes us conscious, sentient beings, that I think computers and AI technology is going to be a huge help to us as we're trying to start to talk about changing small parts of giant complex systems and see how they might lead to different outcomes. And then if I'm going to throw a medicine, throw trauma, throw psychotherapeutic interventions into this, how that ripple causes changes in everything else. I think it leaves us hopefully being less frustrated why outcomes are not as simple as they are. And then if you want to talk about drug companies, how research is done, how things are funded, how long it takes, and the reason why we're not accelerating at a faster pace, those are good conversations I'll leave for a separate time. But remember, super complex interactions among hypothalamic, neuroendocrine, GI, baseline neurobiology, malnutrition, if I'm dealing with an anorexic, in environments where there might be chronic stress or history of trauma, all of these things impact systems, and we've got to take them all, biopsychosocially together. So, and then of course, so then I'll take it down to the absolute simplest side possible, because where do you go from the most complex to way too simple? In that, like, I think of eating disorders and most mental illnesses, you have to have a brain with risks, right? Our brain has certain amount of stress resiliency, and then depending on what the influence is during different phases of development, trauma, nutrition, other kinds of influences, then in my illness, in anorexia and bulimia, we end up with the state-dependent factors, which is I'm also dealing now with malnutrition and not eating, which further influences everything and gets things stuck. It leads, to hormone changes and other kinds of things. And so, you end up with the illness itself actually perpetuating it not getting better. And then to make my job further complicated, when I start to refeed my patients and make them feel better, initially it makes them feel worse. Worst thing you can do in medicine is make somebody give an intervention that makes you feel worse before it makes you feel better. And so it starts to explain why and how we get stuck with these things over time. So a little bit about eating disorders. So let's talk about, what I have to think about as a child psychiatrist. When we think about, just thinking about pharmacology and pharmacokinetics, now that all these genetic studies are out, your patients are bringing you with red and green lights that probably don't mean crap unless you put them in context. But I think that then looking at things in development can be really important. All right. Kill me when I look at that chat stuff. Let's see if it'll let me go back. There we go. So lots of different things when I'm looking at meds. So obviously when we're looking at meds, we want to make sure we're using the right meds that affect the neurochemistry right, and that we even get them in the right doses in the body where they can create the serotonin changes or norepinephrine changes or other changes we want, if we know what those mechanisms are that actually might make their brain more stress resilient. So one thing is, kids are little, right? So they have a smaller body size. So you would say that there's smaller volume of distribution, so you get higher concentrations. So if you take something like Prozac or fluoxetine with, 72 hours of fluoxetine, another, who knows, week of norfluoxetine, that when you look at 20 milligrams in this patient population, you look at that they tend to run higher blood levels in adults. Now, sometimes I take this to my advantage. I think there's a reason why Prozac is probably the best studied medicine in teenage depression. Teenagers are crappy about taking medicine. You can get adequate blood levels, even at low doses, or even if they're taking it inconsistently. And so just knowing that there's more medicine in there, it's not being gotten rid of too fast, and it's probably creating some more sustained changes, could probably let you see why there might be, some differences that happen over time. Then you're starting to talk about, there's things don't always just go in one way of being smaller. So their liver relatively has more parenchyma relative to body size, right? So they actually generally have faster drug metabolism on average pound per pound than adults. And then as they get bigger, those things sort of change over time. So if you look at bupropion, right, it'll tend to get higher blood levels, or they'll get rid of bupropion, faster than in adults. Affects half-life, affects how much medicine you have in it. And who knows with bupropion, if we're talking about IR, ER, XR, super XR, whatever form they come out to make $1 million next, those things sort of further complicate things. But you have to, look at that and consider that. And I'm going to talk about specifically what that makes a difference of in research-wise and getting meds in kids and how that makes a difference. Relatively more body water, less fat, less accumulation of drug, faster elimination. And I'm going to talk about this idea of constant exposure because the last thing is kidneys, right? So especially with lithium, since we're talking kidneys, right, tends to have harder to get a higher blood level, faster elimination. So you got to consider all these things, and they're not just small adults. And if there's lithium, you need to get blood levels. I'm even getting blood levels for, especially like, the ones Prozac, Lexapro, /Celexa, and sertraline, Zoloft are the most common research meds in kids. And I'm inpatient, especially, I'm getting blood levels on these. And I'm really surprised sometimes that dosing doesn't always equal blood levels. So let's take something like Zoloft, for example, which I think is the most hugely variant one that I see in adolescents. And there's some good studies to show that they get rid of this drug faster, and that there's probably a higher percentage of rapid or hypermetabolizers amongst adolescents. And I see it a lot. I'll have anorexic girls coming in on 250 of Zoloft that are dropping blood levels of 42 nanograms per milliliter. So you're not anywhere near where you need them to be. And then I've even found, for my rich families who are getting all the genetic studies, genetics in your P450 alone is not enough to describe for any individual person of why you're on a certain drug level or not. So with Zoloft, they knew that there was a lot of hypermetabolizers. So there became this question of two questions. Do we need to dose and have a constant blood level to create serotonin changes, to create brain stress resiliency and decrease anxiety and depression? Good question. Don't really exactly know the answer to that one. And then if you do, and you have to give Zoloft 2 times a day, well, if I give a medication 2 times a day and I reduce compliance by 50% by making them take it multiple times a day, does that even matter? Is it better to try to just get 1 dose in once a day and have more compliance? So again, it's a science versus the art of medicine. When we're on the front lines, I got to get that medicine in it, keep them in it, get an adequate blood level, make sure they tolerate it, and then hope it creates the change that I need to see over time, right? And so I think keeping all these in mind in adolescence over time can be important. What do we know about pharmacodynamics, right? So this is not only, okay, so let's say I get enough drug in, I definitely get it in, I get the kidneys and liver and those kinds of things figured out where I feel like I'm getting a therapeutic level, which again, we don't really have the data for in adolescence, so we're sort of basing it on adult data. It might be different, who knows? Then what about binding? What about post-receptor effects? What about interactions? How does that work differently developmentally? We also know that dopamine, serotonin, norepinephrine, that these things are undergoing major changes during development, right? Your dopamine receptors, where they're at, how many they're at, how sensitive they are. This is not a static process that doesn't change during development. So again, limited studies, so I'll point to the one things that we do know. Stimulants, less likely to be abused in adolescence. They're less likely to produce euphoria, right? Probably pointing to some changes in dopamine systems that happen over time. Antipsychotics are more likely to induce metabolic effects in youth, more likely to end up with diabetic, high sugar, 30-pound weight gainers, especially like, Abilify is the worst, right? In adults, you can probably say that depending on dosing, it's a little bit less, certainly than Zyprexa, certainly than Clozaril with weight and blood sugar stuff. But in adolescence, we have this whole subset of patients, probably leptin or ghrelin dependent, something that will have a huge difference and will have Zyprexa light weight gain on the med. So you got to follow those kinds of things. And of course, it's usually the ones that are getting the best response, that gain weight and have the blood sugar problem. So you have to make that decision. Younger age, less tolerability to stimulants, right? A 5-year-old has about a 50% chance of having a mild to moderate side effect from a stimulant, 10-year-old, less than 20% chance, right? And so sometimes when I'm treating super ADHD kids who can't even survive preschool, we try a stimulant, I'm warning families, there's a much better chance it'll have a side effect. Doesn't mean that that same medicine will have that same side effect when they're 10. Happened to my own son, who's now in high school, but we tried a stimulant when he was 7 or 8. He had every typical shrinks kid, every side effect under the book, just had to go treat other stuff and do things, and then started taking it again when he was 11, and it works great. And now he's doing better. So again, those things are a moving target. Valproic acid, hepatotoxicity, more sensitive in adolescents. You got to watch that. Lamictal or lamotrigine, which certainly with patients in depression and limited options, I know I use a fair amount for augmentation for depression. But the risk of rash, and this probably extends out, to Tegretol and valproic acid. Remember, Stevens-Johnson's is not a Lamictal only kind of thing, but greater risk. And so my pharmacy has to stay on me because I'm going like 25 milligrams every 2 weeks. I try to get up to at least 100, but that both rash and Stevens-Johnson's risk is identified as increased in adolescents. And then SSRI and suicidality. I mean, if there's anything that's sort of the greatest like psychiatric thing in the last 20 years of like, okay, how are adolescents different? How do we treat them? We always freak out more when a kid's younger as well too. And so let's talk about that a little bit because I think it's important and highlights some important things. So 2004, right? And so I was in the midst of, just coming out of just getting into fellowship, is coming out. The FDA review, this is real science, right? Young kids, probably due to neurodevelopment, it's probably a worse impact between 12 and 15 than it is 15 to 19 than it is 20 to 24. But doesn't also stop when you're 18. That probably extends up neurodevelopmentally into the 20s. There's a small percentage over placebo, probably in the neighborhood of a couple percent, that have increased suicidality. Now, is that due to probably increased irritability or effects of irritability or brain stress resiliency? Probably so. But in a population depressed and anxious, tends to lead to increased suicidality, which just tends to what, ping and get people's attention. So there really is a risk, right? And checking up on a patient after a week or two, I always just kind of say, hey, if you have any side effect more than mild, any change of increased irritability or problems, let me know, stop the medicines until we can talk again. I see him again at 1 to 2 weeks and with changes in doses. Now, the interesting thing I found clinically is I really haven't had somebody who's never had a suicidal idea in their life start on an SSRI and then all of a sudden become suicidal. I think it's that a small percentage just makes them more irritable. And if they're tending to do that, it makes it worse, especially if there's not other interventions. That's why we know that when you add CBT, there tends to be lower SI issues. But now let's look at the bigger picture, right? So not enough child psychiatrists, pediatricians freak out, the whole of Canada freaks out, start to put black box warnings, let's not give these medicines to kids. And then we're keeping suicide data in kids, right? And for the first time in 2004, 2005, we start to see a blip of like less SSRI use and increased suicides, right? So it's always putting things in perspective. Yes, this is a real risk, but also untreated depression carries suicidal risk too, probably greater than carefully using SSRIs. And then there seems to be, for whatever reason, some use less in Lexapro, at least in the dose they used in the study they did in adolescents. So again, it's putting these things in context, understanding there is different reactions, but also not overreacting and understanding, well, what's the side effect of the medicine? Well, what's also, the side effect of non-treatment? Yeah, someone had brought up, of course, from the escitalopram is probably underpowered to test. Yeah, and of course, done by the drug company, we can go through with that. Let me look another one of these. Okay, and somebody else is talking about twin studies, which is always good, and genetics and those kinds of things. All right, yeah, so, and this is, and I know you guys have excellent faculty who do excellent research as well. I mean, this is the difficult thing about doing research. And then the difficult thing that, the reason I'm working with Saeed here of trying to figure out research, real life, how things work and how things translate as you get out over time. Because, if you're on the front lines, if a medicine only works if you're carefully keeping somebody and having a certain blood level and making sure they're definitely taking the medicine, that's not always real life. You got to take in other factors. All right. So, I'm going to go through, and so what I'm going to do for the rest of these, I'm going to go through certain common, things that we treat in psychiatry, and then talk a little bit about development and how that impacts me, and then give a little caveat at the end of saying, okay, now if I add, and especially it'll be with anorexia, if I add malnutrition and eating disorder issues, clinically on a daily basis, how's that further impact me? So child psychiatrist, certainly ADHD, we see nice, and it's probably one of the, other than the fact that you get concentration problems with anxiety and depression, those kinds of things, at least a cleaner frontal, prefrontal lobe illness, neurodevelopmental. We certainly know things like severely premature infants have much, much higher rates of ADHD if that frontal lobe doesn't cook enough. So there's developmental things that we know this has to do with executive functioning, frontal and prefrontal, especially prefrontal lobe, especially dorsolateral prefrontal lobe development, which affects thinking, planning, impulsivity, how it controls the rest of our brain, et cetera. Worldwide prevalence, 5%. Obviously, a lot of variability, right? And I think whether you're talking bipolar, autism, it also depends, like, you're drawing up these boundaries around neurobiology and what do you tolerate, what's normal. If it's autism, like, when can you just be a super nerdy engineer who doesn't like hugs, and when do you have empathy and emotional processing issues that really impact you, and what's that gray area, right, that happens. And so ADHD, I think too, what's the tolerance of, what are we doing at school? How fast are we expecting them to read? How much stress is on them at the same time, which can cause problems. All these things, when you lead to diagnosis, can cause variability. So, but, some symptoms, see it earlier. I can certainly go into females and inattentive ADHD and how hard that is, especially if there's anxiety and depression present, both which affect concentration and memory. But what do we know about treating ADHD? Stimulants, one of the few medicines as child psychiatrist that works right away, works 70 or 80% of the time. you're going to at least know something one way or another. And the one thing that will cause, a mom or a teacher to come hug your neck because the kid's a completely different kid. Now they can be successful and read and do those kinds of things. What do we know about how these work? There tends to be this sort of default mode, task negative neural circuit, that becomes increasingly deactivated as attentional demands increase. The suppression is impairing ADHD, leads to attentional lapses, and I think this helps sort of this default mode. And here's where it gets complicated, right? In the real world, is that okay? And I have a kid with ADHD and anxiety issues. Where does the ADHD and prefrontal mechanisms end, and where does affective limbic stuff begin, and where do those two interact, right? Because so ADHD tends to cause problems because sometimes kids will have emotional outbursts or they'll act out, right? Well, they already have these developing limbic systems and they don't have a lot of brakes on their cars to deal with. And so, thinking in real life too around ADHD and behavioral mechanisms, and especially if they have comorbid depression, anxiety, bipolar disorder, trying to think about these interactions become important. What is it? Anxiety is a great example, right? If I'm anxious and I overthink things and anxiety makes me act out and do things impulsively, then, some more ADHD medications might help rein in my brakes and make a better decision. On the other hand, too much stimulant tends to make anxious people more anxious, right? And so, in the real world, looking at that balance can be important. We have atomoxetine or Strattera. There's another new one that just came out. I'll wait and see when there's more studies before I start using it. But anyway, looks at norepinephrine. It's a different, unique system to help out, probably due to creating dopamine and prefrontal changes on down the road, especially in younger kids, especially those who don't tolerate stimulants. We're using, guanfacine and clonidine, and then the long-acting forms, Intuniv and Capve. These, the question of whether this just chills them out, slows them down, helps with hyperactivity, versus even together with stimulants or otherwise creating some sort of synergy that actually more completely treats ADHD is an excellent question. Someone should research that. And my consideration for eating disorders is, okay, is there clear ADHD pathology? And this is not a perfectionistic person who just is not eating enough and so they need a stimulant to survive. Do they want a stimulant to appetite suppress them so they don't eat? If they have ADHD and I give them a stimulant and they're trying to learn to eat in their meal plan, am I going to totally jack up through appetite suppression, their ability to learn that? So there's a lot of considerations here. I definitely get eating disorder patients that have ADHD. I want them to function well. I've had a fair amount of luck with the those with not super hyperactivities doing well on Strattera, at least as a beginning step, but or carefully once their weight's fine and once they have a better idea on maintenance meal plan of slowly introducing stimulants. But again, can get complicated when you have patients with a lot of anxiety and depression, which causes memory and concentration issues, which they want the quick fix of the ADHD stimulant, and complications when you're using medications, especially stimulants, which significantly impact psychopharm and depression. So, the first thing is that, especially if you're having to take boards, so you're a resident, always, if there's anything about school dysfunction, it's always depression. Just know that. That's the quick thing. But different from adults, when I see adolescents that are depressed, higher amounts of irritability, more pronounced anhedonia. They're stopping interest in things, friends, sports, other kinds of things. Higher somatic symptoms, especially the younger you get and the less sort of prefrontal and frontal development you have. So they'll tend to experience their emotion and their depression in stomach aches, headaches, somatic symptoms. And so looking for those things and not chasing out the different things and maybe coalescing for depression, or the way I look at it, brain stress resiliency issues. Prozac, Zoloft, Lexapro definitely have the most data. Does that mean they're the best? No. As I'm starting to look at some, especially 16 and 17-year-olds, and I always see the ones that have failed everything, right? And you're looking at things. Then, starting to look at dual acting and Pristiq become important. What do we know from real studies that we've done? TAD study, which I worked on, and the Tordia study. TAD study really showed that, basically Prozac works, therapy works, together they work better, and so certainly the common advice of, and who knows, other therapies might work, they happen to do CBT in this study, but that you're seeing some additive response from doing both and should be prescribing both. The next one's really interesting, right? Because especially when you're dealing with resistant depression, which is hard enough in adults, and then you get to kids, it gets much more difficult, because what happens when you've been on 2 or 3 SSRIs and either they have bad serotonergic action or they just don't get better on SSRIs alone, where do you go? So this was a study where they looked at one SSRI. At this point, no Pristiq or Cymbalta out, so they exchanged it to Effexor, which has its own issues, right? If we're going to talk about fast metabolism medication, serotonin withdrawal problems, issues now in adolescence, there's probably lots of complications to this study. But the goal of remission, because in adult studies, that's what you're seeing, right? More complete, dual-acting medicines seem to have more complete remissions, more completely better than SSRIs alone. And what they saw is they saw some more side effects on the Effexor and didn't see better response rates rather than just trying a second SSRI. Now, what's interesting developmentally is we know that serotonergic systems develop more rapidly than noradrenergic ones, and that I don't think you can say a 12, a 14, 18, 20-year-old Sayans have exactly the same response, right? When I've dealt with some resistant OCD and depression stuff, especially in 15, 16, 17-year-olds, I've had some good luck with Pristiq and Cymbalta if I can, get blood levels and get things right? So that there is this thing of, as that noradrenergic system develops, which probably individually develops different from patient to patient as well, you might start to look more like adult getting that noradrenergic help for different symptoms of depression to cause more remissions. What else do we know? ADHD, OCD, conduct, PTSD, eating issues, they all affect treatment response, right? You got to be at least 90% nourished to have adequate serotonin levels for medicines to work. So how many times I see anorexics who have failed every SSRI known to man, but they've had to be, they've had body image, they've had percentage of ideal body weight of 80% that entire time. And it's like, and probably been inadequately dosed and probably had compliance issues. I mean, as physicians, we also got to carefully evaluate, did they use it? Did they use it in a brain developmentally, nutritionally was capable for a long enough period of time at an adequate dose without side effects to determine that this is a failed trial, that for this patient, that this medication is not going to work and we need to move on. And in eating disorders, of course, like nutrition and how much that affects their depression, sometimes just feeding patients makes them more anxious, but also can make depression a lot better. When they're starved out all the time, they can look psychomotor, have psychomotor retardation. They tend to have lower serotonin levels, higher risk of suicidality. That's a reason why anorexia is up there with the worst mental illnesses as far as suicide completion rates. So looking at those things become important. Bipolar disorder. Obviously I could do a whole long thing about this. I actually had the privilege, before I got down the eating disorder road, I worked with, Boris Bermaher and David Axelson out of Pittsburgh. When I was chief fellow at WIPIC at Western Psych, I actually was the fellow that was helping do studies in the CABS clinic, the Child Adolescent Bipolar Services Clinic. And it helps to sort of know history, right? So we know when they start to define bipolar disorder, for a long time, there's been, as they ask patients, they know that developmentally this happens, depression, then bipolar is most common. But then even in the 80s and 90s, there's a group out of Dallas did a study, and they looked saying, God, a lot of these bipolar patients had weird childhoods. Like they didn't sleep well. They had higher rates of ADHD. They had these sort of manic and mood and depressed symptoms that look a little bit different. And we know that this disease kindles. So are we missing something? And so what's interesting is then what happens across the country is everybody's rushing to understand childhood bipolar disorder. And you end up having these camps that have vastly different views of what's going on. I'll talk about some of the major ones. So you have a group out of Harvard that's given 3-year-olds Risperdal to diagnose them with bipolar disorder, and that anybody who's had a tantrum in their life probably gets diagnosed with bipolar. You have the group out of Washington University in St. Louis who are using very, very strict adult sort of like criteria to define that. A group out of UCLA, which is a little more mixed. And then I was with the WIPIC group, which is probably a more moderate group as well. And all, I think, trying to define still, when you see these symptoms, A, what happens when you treat them, and which ones end up really having bipolar disorder in adults. We did these grand rounds at WIPIC where we would take adolescent patients and talk about their hospitalization and study, and then interview them 20 years later, right? And I remember vividly having one who had a full-blown manic episode when she was 15, and then never had a manic episode again for the rest of her life, and was really treated for depression and anxiety, but was like on 20 of Prozac and doing great, and then counting and having no problems. Again, we could talk ad nauseum about all the other things that could have happened, substances, things that weren't reported. But this idea, I think, of looking developmentally at this illness because of kindling, looking at early bipolar disorder and how you treat it, looking at lithium and treatment and how that works, especially in kids, all important things that good people are doing research on. But I tend to be conservative, and I think you tend to see people, people in crisis in the hospital, I think sometimes overcall bipolar disorder. And then some people aren't recognizing it. Different populations, depending on skin color, stereotype, might get overly or underdiagnosed with bipolar disorder versus schizophrenia. Again, great questions and things worth looking at. And of course, looking at things, we certainly know lithium, valproic acid, Depakote, all the atypicals, and this, I apologize, I think I did at least the meat of this presentation a few years ago. So, keep on releasing atypicals. Who knows if they're just different versions of the same thing. God bless the drug industry and the whole 4 companies that still survive out of it. But again, atypical antipsychotics, which for their nature are the smart bombs. If you ever look at some of Stahl stuff or whatever, what receptors they hit. I mean, what don't they hit becomes the better question. Sometimes over time, it's probably the reason why Clozaril works for everything. So, we're starting to see these things. There's some good pediatric studies that look at combination treatment with lithium and Depakote with lithium and atypicals. And in working in the CABS clinic, we were conservative with diagnosis, more so, a little bit more maybe aggressive than they were out of Washington University. But still, like, you had to treat the ADHD. We're learning now probably that earlier bipolar symptoms probably is an increased severity of case, higher propensity of mixed symptoms, all these things, earlier substance abuse, all these things which make it more complicated and more difficult to treat. And eating disorders, my deal is make sure you have the diagnosis right. Make sure that anxiety and mood lability and having ups and downs and people doing their own research and calling themselves bipolar, describing things as manic that are just impulsive or other kinds of things, just make a good diagnosis. And the problem is, if somebody really has bipolar disorder, all these dang meds at work really jack with carbohydrate craving mechanisms. They jack with body weight. Patients look up this stuff online. And so trying to figure out, like, can I get them to take it? Let's make sure it doesn't get them way over body weight. Let's make sure they're bulimic and doesn't make their bulimia worse. You've got to look at all these things. Do we try to use some ziprasidone? Make sure they take it with food, et cetera, so that I can get a better, response, and I'm not going to get weight gain or carbohydrate cravings or problems that takes it awry. Good questions. I mean, thinking about the big things, and this is, to me, my soapbox of why it's important, of how important psychiatrists are. That I think mid-levels are super important in our health system, but the understanding of physiologic processes and how things work and brain development stuff does take sort of medical school and residency training and understanding to understand the nuances. Anxiety, OCD. Remember, as in depression, girls are more likely to get. Let me check the chat here. comment on menarche. Yeah, that's always a good one. Ovulation, cycling, not cycling. Yep. Great questions. Yeah, I'll definitely address that. Anxiety, OCD. Again, girls more likely. Definitely puberty is important. Hormones, they definitely are important. Most common disorder, right? I think, especially because the most common form of brain stress resiliency. OCD is 1%. It's almost 40% of anorexic. So, how do we take that biology and put them together? Certainly, we look at SSRIs. The duloxetine was approved in 2014, and I for some reason, I have had some luck in resistant patients with SNRIs, especially as they get older. Benzos, someone mentioned, just complicated as heck. You definitely get people who give them out like they're candy, people that never give them out or only give out clonazepam. What I know in kids and adolescents, they get more behavioral disinhibition. And I found in the eating disorder population, they're not potent anti-anxiety agents. I get almost as much reaction from Vistaril, if not with much less side effects around meals than I do with Ativan, right? And so how do we start to not only think about development and different things, but even different diagnoses, different brains and how they might respond differently to different interventions. Buspirone, probably safe, not enough trials in kids, just like everything else. And in eating disorders, it's really, this is usually the central core of what they really have, right? And eating becomes a way for them to modulate it. It helps them turn off their hormones and their estrogen, which makes them less anxious. It helps turn down their serotonin levels, right? Which makes them dull and boring, but it also reduces their anxiety. And so you can start to see sometimes how behaviors will further things along. And that for most patients, getting their brains nourished enough for their chemicals to be right, and then using the right medications and therapy to treat their anxiety and have them use other things other than food-related resources to take care of their anxiety, just like you would in substance abuse with drugs and alcohol, becomes very important. All right. And then perfect timing. So I'll finish up. I think this might be my last slide, and then I'll have some time to take questions. And then I think if they wanted me to stay on with the residents, I'm happy to do whatever they have an interest in doing. So for me, one of the most difficult things, the baseline of my anorexic patients has to do with nutrition, right? And certainly this has to do with anorexia, but this could be if you're trying to practice psychiatry in a third world country or in certain urban areas where malnutrition is prominent. Again, understanding the baselines of how different conditions affect psychopharmacology, affect physiology, and affect, how drugs work can be important. So what do we know? SSRI depends on neuronal release of serotonin. If you restrict food, we know that decreases serotonin and its synthesis. If I take one of my malnourished patients and I put a needle in their back and I get 5 HIAA levels, they're low. We also know those low levels can correlate with suicide. And so there's maybe some increased suicidal risk because they're malnourished as well. How do you make serotonin? Tryptophan. If people are dietary restricting, they don't get that as well. And so we end up dealing with the fact of, I'm dealing with a system that's downregulated and I'm using medication which is trying to stop the reuptake. And then I get frustrated why I don't get robust responses. Even, Walt K, who I worked with and have a huge amount of respect for out of Pittsburgh, is out of San Diego now. They did this study with Prozac with anorexics that showed some benefit of patients with anorexia going on Prozac, and it seemed to lead to less hospitalizations, better outcomes. However they wanted to measure that. That's a whole different question altogether. And then they did follow-up studies which didn't show that it worked so well, right? And then the question becomes to me of, well, how many of those patients had premorbid conditions or underlying pathology that really would respond to an SSRI like Prozac? Do you make sure they were getting it? How much did their differences in follow-up and nutrition maybe make in their ability to have sustained response and to have less relapses from their anorexia? Again, there's so many other things that go into play that become important. Next is gonadal. So someone asked about estrogen. And so, watching and looking at, especially in eating disorders, because now we're seeing more male eating disorder patients talking about sex hormones, talking about testosterone, estrogen, interactions with neurochemicals becomes extraordinarily important, And so for me, child psychiatrist, most of my practice under the age of 12 is boys. Most of my practice over the age of 12 is girls. And I think there's reasons why that happens. And so some of it is that evolutionarily estrogen, my daughter's 14. I don't want to have a kid anytime soon, but physiologically 13 or 14, when you're hitting, or now 11 or 12, thanks to whoever knows what, when they're hitting puberty, those estrogen levels rise. And actually that earlier puberty and earlier exposure to estrogen probably has more of an impact on the brain, more of a chance of depression, anxiety, never mind early development and earlier and more frequent sexual abuse. So, but what I think happens is that those hormones are another stressor on the brain. And if you have a brain with stress resiliency issues, then you're leading to higher rates of females having depression, anxiety, OCD, eating disorders than males. And that the other thing that makes me think of, because also what happens to my anorexic patients is when you lose body fat, you lose that conversion to estradiol, right? That you need peripheral body fat. They stop having periods, right? And so it's another way in which they create second-handedly relief for themselves, right? If estrogen makes my brain a little irritable and I get rid of it, it's decreasing my anxiety levels. Not great, creates other problems, but it can create benefits. The same reason when I'm treating female patients and I'm trying to think, is this medication making a more stress resilient brain? I'm trying to make sure, how is it the week before your period? How do things work? And in my patients, I'm very surprised that if I send my patients, so I have them weight restored, but their estradiol levels are still a little low. They're still sort of restricting eating. They don't have their period back. If I send them to an OB-GYN, they're either gonna give them a progesterone challenge or put them on birth control. They're not gonna think about, well, what's your body fat percentage? Do we just need to get your weight higher? I see so many patients that doesn't happen over time. Another chat question here. Serious starvation not affect. What serious starvation not affect? Is reduction of serotonin specific or more than what? Yeah, great question. And it's that slide earlier, right? So I think because of serotonin and tryptophan, because of how easy it is to monitor serotonin levels in your peripheral bloodstream as well as the CSF. I think they're all impacted. And unfortunately, people done more serotonin research than anything else, so I can talk about that from research. But you're right. I mean, that whole busy slide I showed earlier, when you starve somebody out, you jack that whole system up. I get TSHs that go up and hypothyroidism, the whole hypothalamic axis goes off. And then again, here's the solution. If I feed somebody right, get them back to their genetic ideal, if I feed and water them right, and as I say, and get them better, medicines are going to work better, therapy is going to work better, life's going to work better, relationships are going to work better. It's a foundation on which a lot of things are impacted. And great opportunity for research. How does malnutrition affect other things? Here's how few studies there are. I am finishing up a study where, like, if we take fMRI, so we do fMRI research, right? No one's done the research to say, if you take a brain that's malnourished and nourished, how does that affect the bold signal in an fMRI, right? And that makes a difference for all of research, right? And what we're determined is that because of blood flow and other reasons, we took the same brains, nourished and not nourished, and showed that even fMRI data on a simple visual task looked different, right? So you're doing all these studies in fMRI, sometimes you have mixed undernourished and nourished patients or other kinds of things, and you don't even know that you're comparing to apples when that happens. On top of that, you're right. Whoever asked the question, how does norepinephrine? And nothing exists in a vacuum. So when you impact serotonin, it probably absolutely impacts the others. And nutritional components are important for that as well. So great question. Do the research. I'd love to see it. And then, folate, folic acid, especially in female populations. It's pretty easy nowadays. We can do it in-house here at St. Francis and Laureate. Let's check on MTHFR. Let's make sure that there's not something we're missing that's not making the substrate. I mean, certainly when you don't eat, folate stuff gets messed up. another way in which, not again, for this, it's all the monoamines, right? Not just serotonin that get impacted, and that can certainly affect it over time. All right, there's references. So I will. Okay, so I'll stop my screen share so that doesn't happen. So you can see me. And now I can see all the questions. All right. How does significant starvation, BMI around 15 or less, I've seen as low as 11, 10, affect cognitive functioning? For example, a slum score of 18, how reversible is it and how quickly? So this is where I'm going to do my admitting when I don't know a specific score. So whoever said that question, what does a slum score measure? What kind of cognitive functioning? Because I'm not familiar with that test. As you're kind of giving me exactly what it is, I will talk to you about, I did a presentation recently that looked at, same as many mental stats. Okay. So here's what we know. When people are significantly starved out, it seems like, especially myelin and sheath and supportive astrocytes seem to get hit hardest and first, right? And these supportive mechanisms of the neurons tend to get hit more hard. What we know is it does lead to them having cognitive slowing and those kinds of things. And the nice news is if they're young enough and there's not sustained enough damage, which most damage in any system in anorexia usually takes decades and not just years, that they tend to get it back once they're back nourished pretty quickly. But we see changes. There seems to be a lot more changes in cognitive processing than there is actual effects themselves, and processing speed. I think this is where my population is so skewed, right? I don't do a lot of MMSEs even on my severely malnourished patients, but I am also skewed with a population that tends to be more overly intelligent and highly educated, which again would make these MMSEs harder to do. They're going to do better at that. So I didn't even see a lot of studies with malnourished patients with these. They were looking at more cognitive processing issues and those kinds of things, because those are harder to fake based on knowledge base and based on your intellectual capacity. But good question. Other questions? And I don't know, you can also, if I can hear it, I don't know on this computer, do it by text or unmute yourself. I'm happy to do either. And I've got like 5 minutes left, and I don't know if the residents are hanging on for me to talk. All right. Well, I absolutely wish I could be there in person. My hope is I have plenty of other topics to talk about. I don't want to hear from me too often, but in a couple, 2-3 years, and hopefully when the 15th strain of coronavirus and our T cells are finally used to it enough to keep us immune, that we can sort of meet in person and go from there. So what is a circuit underlying anorexia nervosa? I would take whoever asked that question and say, what do you know the best and what's the circuit underneath there? And the answer is super complex, right? So there is certainly seems to be insular changes that happen in this population. So right now, let me talk about a little bit of research we're doing, and that'll go back. So there is insular changes. There's other limbic system changes. There seems to be prefrontal cortex changes, especially ACC changes related to OCD, which tend to be important. But let's, and I think as you sort of do anything, you see how these things connect. I also think there's more pathways into restrictive eating than just one, right? So I have patients with horrible body image dissatisfaction. I have patients with less so. I have patients that basically have orthorexia and clean eating with lack of seriousness in their condition, and it's more of an OCD thing than they actually care about their body. So I think, again, there's sometimes is lots of motions down to sort of restrictive eating, low weight, lack of seriousness, and body image concerns. But, the circuit that we're interested in is the insulas really are, especially anterior cingulate, or anterior mid insula, pardon me, is probably this connection between our gut microbiome, our rest of our nervous system into our brain. And so what we know when we've done studies, fMRI studies, is that people with anorexia, as compared to people with depression and anxiety, who we see their insula also misprocesses bladder information and breath information and the other things that the insula does, that there tends to be in our population an overconcentration in the gut. And then the question you have to ask is, how much is top down? How much is anxiety, overthinking? And as I do that, it gives me a nervous stomach and I don't want to eat. And then it jacks with my microbiome because of anxiety and my decreased food stuff. Or how much actually is their GI systems actually work differently and the microbiomes differently, and it takes things upstream and affects things genetically to make them sort of more anxious and avoidant. And so right now we're doing the simplest study, which is how do you modulate the GI system? Well, we're using a vibrating capsule. And then we're looking at anorexic patients, non-anorexic patients, and seeing how they even perceive the same sort of GI sensory information to look at differences and to see how that works. We've actually done some flotation research as well too, where we sort of take the insula offline, right, through not sensory deprivation, but through floating, and found, again, anxiety release and different responses in people with anorexia. And I think this is how we start to do the studies. We start to look at reactions to things, and then we start to put pieces of the puzzle together with specific neurobiology. So that's the short, long answer to your question. All right, I think that leaves us just about like 2 minutes till, so I'm surprised because I haven't done this presentation a ton or over an hour and a half, but I appreciate you guys being here. I'm gonna go ahead and hang out. I understand that the residents, whether they want to or not, are gonna talk for a little bit, and I'm happy to answer those questions. You're always welcome to reach out. My email is SEMOSEMAN at St. Francis, spelled out SAINTFRANCIS.com. Happy to consult, happy to talk about eating disorder patients. I see a lot of Wichita patients. You guys have some great practitioners, but no child psychiatrists around that see them. So I have patients that drive or see them inpatient. So I'm happy to help. I did have one more question that came up that I'll answer in the last minute before I meet with the residents. Oh, thanks, Heather. Is it correct that patients with anorexia nervosa, even in remission, have a shift to the left, more sensitive to gut distension by a balloon inflated in the bowel? Yeah, we talked about the study where, of doing something. The studies don't show it. My guess would be yes. And then the question is, do they have microbiome and gut sensitivity? I really think there's more top-down action than there is bottom-up action that's happening. So yes, I think over time, they're going to be, so I'm an anxious person. I'm a gut anxious person, right? So the symptoms are real, right? If you have irritable bowel and you get diarrhea or constipation, you can't make that up. Those are real physiologic reactions. And again, the more I do research and try to separate the brain from the rest of the body, the more I think the integration becomes important. So I do think they, just like they maintain low self-esteem, lifelong, more sensitive guts. And then the problem is if you send them to a GI specialist, complicates everything. They diagnose them with small intestine bacterial overgrowth syndrome and other kinds of things. And they want to put them on selective diets, which when you have anorexia tends not to go well. So again, collaboration, looking at things. I think that there's some long-term baseline things that they have to fight through. All right, so thank you everybody. And we'll stick on the line and wait for whoever's going to direct me with the residents.
All right, yeah, thanks. I appreciate it. So medical students are welcome to stay with the resident session afterwards, but thanks everybody for coming for the main presentation.
Thank you, Dr. Mosman. It was nice to meet you.
Nice to meet you.
Yes.